So the next speaker is Tassos Kyriazoglou, and I apologize for my very bad Greek. And he's from the Medical Oncology Unit in Attikon University Hospital. And it's remote.
Hello, good morning. Thank you for the invitation. Just give me a second to share my screen. Here we are. And now, just a second. Okay, is it okay now? You can see?
It's more than okay.
Okay, thank you. I would like to thank the organizing committee for giving me the opportunity to participate in such a nice congress. I'm going to discuss about sarcomas, and I have to say that I'm a medical oncologist. So my view comes from this side, and I always like to start my presentations with the guidelines. These are the European Society of Medical Oncology guidelines for bone sarcomas. What I would like to show you is that both, for at least the common, the osteosarcomas and the Ewing sarcomas, there is there is indication of chemotherapy, neoadjuvant, adjuvant, and plus or minus, at least for Ewing sarcomas, radiotherapy. When we go to soft tissue sarcomas, you will see that the guidelines, they start to have those plus or minus things. So it's not very strict, the possibility of giving chemotherapy or radiotherapy or both of them in the neoadjuvant or the adjuvant setting. And it's even more vague when we discuss the unresectable or locally advanced soft tissue sarcomas. What I would like to show is that our trials, when we give adjuvant chemotherapy or just the follow-up, you can see that around 5 years there is a 40% possibility of our patients being experiencing recurrence and dying. Even the randomized trial of EORTC showed exactly this thing, that about 50% of our patients will probably recur even if they get or they will not get adjuvant chemotherapy. When we changed this setting and we went back to the neoadjuvant setting, this is the most recent trial. Unfortunately, the results were the same, which means that in the neoadjuvant setting, after 5 years, there was a possibility of 40 to 50% of our patients experiencing recurrence. So I wanted to highlight that there is a great place of great room for extra therapies, for better therapies, and at least a meta-analysis, a very recent meta-analysis of neoadjuvant chemo and radiotherapy in several soft tissue sarcomas, that they achieved pathologic complete response, shows excellent overall and disease-free survival rates for the patients that they have zero tumor viability after the neoadjuvant therapy. So what do we do here in Greece with sarcomas, and why we participate in such a meeting? First of all, we have the Greek sarcoma group, Greek sarcoma and rare cancers group. We have our own national registry. We run clinical trials, both national and international level. We do research, again, by participating in international projects, but also running some national research projects. And of course, we have already managed to organize our sarcoma patients in order to create a patient advocacy group. And what about proton therapy? Because I have to discuss it. The truth is that I had to search literature to show you that, of course, there are indications for proton or carbon ion radiotherapy in sarcomas. And which are these indications? These indications are usually directed through the location of the sarcoma. So head and neck, skull sarcomas, retroperitoneal sarcomas, breast sarcomas, pelvis is such an important location. Spinal and paraspinal sarcomas are locations that we should provide to our patients the possibility of getting proton therapy. And of course, we already have good results. The previous speakers discussed chondromas, rhabdomyosarcomas, Ewing sarcomas, chondrosarcomas, radiation-induced sarcomas, and osteosarcomas are those histological types that they seem to have. They seem to get an important benefit from proton therapy and or carbon ion therapies. And I would like to discuss, the real world data. So in Greece, we do have around 400 to 500 new diagnoses of mesenchymal tumors in general. Every year, I would like to say that the majority, the great majority of these 400 to 500 mesenchymal tumors are sarcomas. So more than 250 to 30 to 300 300 cases per year are the sarcomas diagnosed in Greece. I have searched because you know that we did not have proton therapy in Greece. So we have to send our patients to other European countries. Mainly, we send them to Italy. Barbara Rombi is participating in this meeting. We have already a couple of patients with her, or in Germany, people from Greece. They tend to go to Germany. So 3 to 5 cases, they manage to be referred in other European centers that they do have proton therapy. And I say that they manage because the answer is above. The average cost of the therapy is 30 to 50,000 euros per patient, and it is covered by the Greek government. But on the other hand, the rest of the costs are not covered. Travel, accommodation, cost of living is not covered by the Greek government, and the patients should cover all these expenses on their own. So the real world data is that 3 to 5 cases manage to go to a European center to get proton or carbon ion therapy, but the real number of patients that they should have been there is, of course, bigger. I have these 2 photos. I think that we like to discuss about equity. We like to discuss about accessibility to good treatments and to be fair with our patients. But in rare diseases such as sarcomas, I think that we do not have it. And I believe that you realize that, at least from the numbers that I have shown here in Greece, equity for sarcoma patients is not something that we have achieved. And I have to say that as a medical oncologist, I totally don't like this thing. So I would like to finish my presentation by showing you that we have this Greek sarcoma and Rare Cancers Group, we try to organize to make a good network of medical oncologists, surgeons, radiotherapists, pathologists, of nurses, of researchers, and of course of our patients, in order to create the right pathway for our patients from the diagnosis to the best treatment of a sarcoma. And I would like to thank you, and I would like to highlight again that radiotherapy, carbon ion and proton therapy in Greece for sarcoma patients has to grow, has to do something better. And thank you very much.
Thank you for being on time. In fact, you were a little fast. There is time for questions. Can I ask you, what is the follow-up of these patients that go abroad? How do you do the follow-up then? Do they come back to Greece and you have a particular arrangement with the center and you do the follow-up separately? How do you do the follow-up on these patients?
Usually we do it here and back in Greece, and I personally contact the radiotherapist. I told you that I have shared patients with Barbara Rombi in Trento, so I always do the follow-up. I inform her about the radiological assessment of the patients, and I always ask her whether she would like something extra. At least technology can help us, so sometimes I send her the images, the raw images, and she can compare with the images that she already has while she was designing the therapy, and we try to follow up the patients in this way.
Thank you very much. Any follow-up?
Yeah, I have a question. I'm not a doctor, but I understood that this kind of diseases are the must do with carbon. Of course, when I ask my colleagues, they always tell me this is personalized one by one. Of course, one has to see, but I thought that this is exactly the cases for carbon ion therapy, isn't it?
Yes, of course, my talk was focused on cordoma, but carbon ions are really indicated for radio-resistant tumor. For radio-resistant tumor, the big area of sarcoma. Sarcoma for hybrid of osteosarcoma, where like the cordoma, we found big mass in this region. With very disabling surgery, and we know that nowadays we have a good surgeons with good reconstruction, so some patients can have good results. But in these tumors, cordoma and sarcoma, it's very important to have a wide margin. So sometimes it's not easy to have a wide margin, and without wide margins, the recurrence is for sure.
You also mentioned.
Yeah,
sorry.
Thank you.
Just to let you know that there are several types of sarcoma. Of course, as Maria Rosaria said, there are radio-resistant sarcoma as well as more radio-sensitive sarcoma. For that specific case, actually, we treated a couple of cases. There was a very good indication for proton radiation. It was not radio-resistant tumor, but it was just to let you know that, yeah. So we are on the same boat, actually.
Okay, sorry, but your question was, I interpreted your question as a general condition. Okay, so this I completely agree. In our center too, we have protons and carbon ions, and in case of radiosensitive sarcoma, we use the proton for sure.
Also, you mentioned the numbers, let's say, of patients that were sent from Greece abroad. And now I will say things that I should not say in public, but I was involved with this TNA, Transnational Access Project, through HITRI+, and through Mr. Bukovinas that you collaborate with. And actually you are standing here for him not being able to give the presentation. We sent several patients abroad. And it was a very painful process. First of all, most of them, they were rejected by the Greek national how can you say, insurance system. And then it took a long time, really a long time. And the people does not wait. So I was a little bit stressed with this. And this is also along the lines that you say that the real numbers, the real statistics we have do not reflect the reality. You know? So something has to happen there with your associations that you have, and maybe you can push along this direction.
So Tassos, that was a comment, not a question. The question is coming out from Sami. Do you want to go for it?
Yeah, thanks. Great presentation. I just wanted to add, because you were asking, Jutta, whether these are suitable candidates for carbon. I absolutely agree. And it's rather a comment than a question. It is extremely important to have this interdisciplinary exchange also with the surgeons, because as you said, when they do surgery and it's not with wide margins, it's useless. It just causes harm, it causes side effects, and then you have a multifocal recurrence and you can't treat with carbons anymore. Carbons gives you the possibility to avoid surgery in certain situations, especially mutilating surgery in these large pelvic tumors. And it is a very important option for patients to increase their quality of life.
So we have one question in the chat. Tassos, can you read the question, or do you want me to read it out loud? So the question is, what is the prognosis in intraperitoneal sarcomas, and what treatment do you suggest? If it takes less than a minute, that'd be great. If not, but please, yeah, try to answer if you can. Oh,
Thank you. I was trying to unmute myself. Yeah. Intraperitoneal sarcomas. This is like an MDT now. I understand that if a treatment, of course, we should have also the histological type of these intraperitoneal sarcomas. But in any case, if we want to give something in the neoadjuvant setting, I believe that it should be radiotherapy, and then the surgeon can have a wide excision. That's my opinion. I try to keep chemotherapy for the metastatic setting. If for any reason we believe that neoadjuvant chemotherapy would do something better for this patient, and if we think that I could help the surgeon with a neoadjuvant chemotherapy, this is something that we have discussed in a very personal situation. But in any case, I totally believe that neoadjuvant radiotherapy and then surgery is the best thing for this for a patient with a localized sarcoma. And of course, it depends on the histological type, and that's a general answer to this question, because it's not very.
Thank you. Anyway, so I think if there are no more questions, we move on to the next speaker.
Just one more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.